So I will be talking about NASH in 2023, talking about current and hopefully near future treatments for the disease. I have no financial disclosures. Topics that I'll be discussing today include definitions in epidemiology, screening for NAFLD, the use of biomarkers and non-invasive tests in an effort to avoid liver biopsies and what's available, current treatment of NAFLD, as well as failed trials and current medications that are under study. So just to go through some definitions, recently, in the last couple of months, AASLD published a new practice guidance in regards to NAFLD, which is actually quite good. I think it's updated since the 2018 practice guidance, and it is a little bit more, going through definitions of things and gives a little bit more guidance on how to manage these patients. So NAFLD, which is non-alcoholic fatty liver disease, is this broad encompassing term that includes both simple hepatic steatosis, the inflammation that's associated with it known as steatohepatitis, as well as fibrosis. So it's sort of that broad encompassing term. On histology, includes at least 5% of the hepatocytes that demonstrate macrovesicular steatosis, and this is in the absence of other etiologies such as drugs or alcohol that can also cause macrovesicular steatosis. Little or no alcohol use is defined as less than 20 grams per day for women, and for men it's less than 30 grams per day. NAFL, so non-alcoholic fatty liver, this sort of just refers to the actual steatosis in the liver, maybe some mild inflammation. And then NASH is non-alcoholic steatohepatitis, which is the inflammation that is associated with the hepatic steatosis, which includes inflammation as well as ballooning. NAFLD is on the rise worldwide. There's also an associated rise in both HCC and cirrhosis as a result. The prevalence is likely underestimated. If you think about the patients that present that you see in your clinics, they're often asymptomatic, and so really it's detected kind of incidentally in many cases. So prevalence at this time is thought to be around the order of 25 to 30% of adults. There is a substantial geographic variance. So you can see here on this map, I know it's a little bit small, it shows that the areas that are most affected are parts of the Western world, so the US, and then also parts of Asia as well. In terms of who should be screened, so this was also something in the practice guidance from AASLD. So you can think about it in terms of 4 broad categories of patients. So patients with diabetes should be screened for both fatty liver as well as for an assessment of fibrosis. That's because these patients have a more progressive disease course, and this should be sort of identified and followed earlier on. Patients that also have a family history of cirrhosis due to NASH, these patients should also be screened. It's interesting, even though this is non-alcoholic fatty liver, patients with significant alcohol use should be screened as well, since we know that a lot of patients do have metabolic syndrome or metabolic comorbidities. And there is a significant interplay between alcohol and non-alcoholic fatty liver disease that also leads to a more progressive course and more progressive fibrosis. And then the last group of patients are those that are obese that also have metabolic complications. So this is actually from the joint guideline from the Endocrinology Society and AASLD. They mention it in their new practice guidance as well, but this was published last year. And it's basically an algorithm on how to screen these patients in the non-GI or hepatology settings, and to basically know when to refer to GI or hepatology. So at the core of this is really looking at the FIB-4, which is the most validated tool for fibrosis assessment using laboratory markers. And so a FIB-4 of less than 1.3 is considered low risk. So these patients can just continue to be followed in the endocrinology or primary care settings per this algorithm. A FIB-4 that is considered to be intermediate, so between 1.3 and 2.67, should have a secondary assessment, so either with elastography or ELF, which is the enhanced liver fibrosis blood test, which is a proprietary test that can be used if there isn't elastography available, can further risk stratify these patients into low, intermediate, indeterminate, or high risk. And then lastly, patients with a FIB-4 of over 2.67 are considered high risk and should be referred to GI hepatology setting. There is a caveat to this. We will be soon publishing data from UCLA that indicates that a FIB4 cutoff of 1.3 may actually not be sufficient to basically screen for patients that may be at risk for progression of fibrosis. And we are sort of advocating for actually a lower FIB4 cutoff of less than 1 so that we can appropriately identify patients that may be at risk, such as diabetics that may have normal liver enzymes and therefore a lower FIB4. In terms of biomarkers and non-invasive testing, there is a shift in the community away from liver biopsies. There are risks associated with biopsies as well as costs. And so there are many non-invasive methods to both detect hepatic steatosis as well as to estimate fibrosis. And these non-invasive measures can also go on to predict liver-related outcomes, and there are data to suggest that that is the case as well. So some of the non-invasive tests that are available to detect hepatic steatosis and for assessment of fibrosis are listed here. The ones that are most validated, and of course we're also in the algorithm that I had just shown as well, are the FibroScan as well as the FIB4. I will have just a small comment about MR elastography. That's a very good test, especially when it comes to detecting F2 fibrosis or higher. So that's also a consideration if that is available wherever you are. In terms of treatment of NAFLD, the tried and true is really healthy diet and exercise. These changes in lifestyle modifications, even in patients with lean NAFLD, meaning that they might not have weight to lose necessarily, but a change in their diet and incorporating exercise may actually have an improvement in the fat content in the liver and potentially could also improve fibrosis as well. So little weight loss, around 3 or 5%, can improve hepatic steatosis. But actually the most benefit is if you're able to lose more than 10%, that can actually lead to an improvement in NASH histology as well as lead to fibrosis regression. And then, of course, since many of these patients also have metabolic comorbidities, there should be adequate control of their comorbid metabolic conditions. Currently, there are no FDA-approved medications for the treatment of NASH, but hopefully this will be changing soon, and I will be presenting some data for a couple of drug applications that have been submitted, and we may be hearing hopefully by the end of the year. So medications that have been studied and have shown no improvement in histology or in fibrosis are metformin, ursodeoxycholic acid, DPP-4, statins, or Silymarin, which is known as milk thistle. The PIVENS trial was published in the New England Journal of Medicine in 2010. They looked at patients. The 3 groups were basically those with vitamin E, randomized to vitamin E, to pioglitazone, or to placebo. And what they found with vitamin E administration, so 800 units daily for 96 weeks, it did lead to an improvement in histology, both in steatosis and lobular inflammation, which was statistically significant, but there was no improvement in fibrosis. A retrospective study corroborated these findings and found that vitamin E was also associated with a lower rate of hepatic decompensation and higher transplant-free survival. There are some controversial data out there suggesting a link between vitamin E and prostate cancer. This is something to just maybe be discussed with patients ahead of time, but otherwise seems to be a possible medication to be prescribed in clinic. Pioglitazone was the other medication that I had mentioned was studied in PIVENS, and they also found that pioglitazone was associated with an improvement in histology in patients with or without diabetes, but not an improvement in fibrosis. The patients did gain more weight with pioglitazone than with vitamin E or placebo, so that was an interesting finding. And there are certain risks to also consider when administering this medication, including osteoporosis in postmenopausal women, a questionable risk of bladder cancer, a potential worsening of heart failure in patients that have underlying cardiac dysfunction. So the GLP-1 receptor agonists, they've been quite popular in the media. I think the Kardashians are taking them, many celebrities. They even made jokes at the Oscars about Ozempic face. So this is very unfortunate, though, for our patients, though, since there isn't a shortage of that medication now. But the two that have been studied are liraglutide and semaglutide. So in the New England Journal of Medicine, there was a study published in 2021. It was a double-blind phase 2b study looking at semaglutide dosages of 0.1, 0.2, or 0.4 milligrams per day versus placebo. And they found that NASH resolution was dose dependent. So 59% of patients in the 0.4 milligram group did achieve NASH resolution versus 17%. And though not statistically significant, there was also an improvement in fibrosis in patients that had 0.4 milligrams versus placebo. But one thing that's kind of interesting is that a third of the patients that were in the placebo group also had improvement in fibrosis. So just take that with a grain of salt. The mean percent weight loss was 13% in the 0.4 milligram group as compared to 1% in placebo. So it is quite effective as a weight loss medication. And there is a phase 3 trial that's currently in progress. For clinical trials, there are many challenges. This is a heterogeneous population of patients with also a heterogeneous disease process. And we know this because there's multiple factors that are involved in the progression of NASH and therefore fibrosis. And so it's very difficult to sort of have a target to treat. Also, the disease progression is very slow. So on average, going up one stage in fibrosis happens on average every 7 years. So it's very difficult to study. And the need for liver biopsies from the FDA as endpoints also makes it challenging to enroll patients. So there are some clinical trials that have been published, actually some drugs that have failed, but their data have shown that using non-invasive tests may be appropriate correlations for liver biopsies. So hopefully that's where our future is heading. So there are many failed drugs. I'm sure there's actually more than what I've listed up here, but these have been some pretty big trials, and in particular, the STELLAR trial. So this is an ASK1 inhibitor that's thought to play a role in NASH propagation, so with injury and fibrosis. And there were two large phase 3 trials that were done, STELLAR 3 and STELLAR 4, which were for F3 and F4 fibrosis, and patients that were randomized to 2 different dosages of the drug and placebo for 48 weeks. And unfortunately, neither met primary endpoint of fibrosis improvement without worsening of NASH. So going on to 2 medications that are actually quite exciting in our day and age and may be approved for the use of non-cirrhotic NASH, hopefully by the end of the year. One that I will be talking about is from Intercept. It's obeticholic acid, already used in the treatment of PBC as well. So it's a farnesoid X receptor agonist, and it is anti-cholestatic and therefore hepatoprotective. There is an ongoing phase 3 trial, but there are positive interim analyses in patients with non-cirrhotic NASH. And essentially that treatment with OCA 25 milligrams demonstrated an improvement in liver fibrosis by at least 1 stage without worsening of NASH, which is one of the endpoints that the FDA looks at. So there was a new drug application that was resubmitted. So just some data to show these are from top-line results that were published presented at AASLD in November in Washington, D.C. So I would just focus more on the right-hand bar graph. The left-hand was the original analysis, and this just really had to do with a difference in how the liver biopsy slides were read. So on the left side, those were just the way back in 2019. It was just 2 different pathologists. One read, some slides, and the other read the other half of the slides. And on the right-hand side, this was actually more of a consensus. So there were 3 pathologists that read slides independently, and then 2 out of the 3 had to come to a consensus about all 3 components of the NAS score. And essentially, you can see here that in the 25 milligram group, there was a statistically significant difference and improvement of fibrosis without worsening of NASH as compared to placebo. The other medication is from Madrigal. So they also had some positive interim phase 3 analyses that have led to a new drug application being submitted. So they had their phase 3 Maestro-NASH trial using Resmetiron. So that's a thyroid hormone beta agonist. And essentially the thought there is that thyroid hormones have many roles in the body, but one of them may be an improvement in lipid metabolism, which is central to the progression of NASH. And so they looked at 2 different dosages, 80 milligrams and 100 milligrams. They had more than 950 patients, and they actually met both primary endpoints. So they met both NASH resolution without worsening of fibrosis and also had improvement in fibrosis without worsening of NASH. So there is a new drug application that's been submitted and potentially could be approved by the end of the year for non-cirrhotic NASH. And here are their primary and secondary endpoints. So you can see here that with the 2 dosages of the drug, those were both statistically significant as compared to placebo in improvement of NASH resolution without worsening of fibrosis, as well as improvement in fibrosis without worsening of NASH. It's also interesting that our secondary endpoint, which is a little bit different than obeticholic acid, which you did actually see a little bit of a spike in LDL, which then normalized. This medication actually has a benefit in lowering LDL as well. This is what they found. So it may be good medication for patients with those metabolic comorbidities. The one thing that I do have to say is that if you look at these numbers, I mean, it's great, they're statistically significant, but they're not great either. So, 26%, 30%, I mean, it's great because it's better than nothing, but it just shows, I think, how difficult this disease process is to really treat and target. So in summary, NAFLD is on the rise worldwide. There's an associated rise in HCC and cirrhosis. Certain patient populations do benefit from screening. So those are patients with diabetes that may have a more progressive course, patients with a family history of NASH cirrhosis, those with significant alcohol use, as well as those with obesity and metabolic comorbidities. There are many non-invasive tests for detecting both hepatic steatosis, as well as for assessment of fibrosis. So that's kind of been a shift in our hepatology community away from liver biopsies. The tried and true treatment of NAFLD is weight loss through healthy diet and exercise. There are many medications that have been studied. Many have failed. We will see who the winners are of the Hunger Games, but medications such as obeticholic acid and resmetirom are on the horizon, may be approved by the end of the year, which is quite exciting. So these are my references, and thank you so much for your time.